Dear Professor Dr. Zoweso, please do the opening remarks, please.
Okay, alo mingla ba. Diနေ့တက်ရောက်လာတဲ့ကျွန်တော်ထင်တယ်ကျောင်းနေရာရောဈေးုံတီးတီးရောမြန်မာပြည်နေရာအနှံ့ပေါ့လေလွတ်မြောက်ဒေသတွေရောနောက်ကျွန်တော်တို့ဒီ conflict ဖြစ်နေတဲ့နေရာတွေရောဗောလေအားလုံးတက်လာတဲ့ဆရာတွေဆရာမတွေကိုကျွန်တော်မင်္ဂလာပါလို့နှုတ်ခွန်းဆက်ပါတယ် Good afternoon for Myanmar and then good morning for Professor Jerome GAUZY. Too early for you, I know.
No.
You're at 6:30 in Paris, at 6:30 in Toulouse, I think. Thank you so much for your time and your interest and also your support to Myanmar and especially for our revolution. And then, you know, in this time of, you know, difficult and critical time for us. And then I'm very happy to see you. And then also that make us strong. Looking at your face, we feel strong. And then, you know, we feel better. And then we feel, you know, winning sense. Thank you so much appearing your face on the, you know, our media and also Zoom and also participating and then involving and then also leading the training program for the combat, you know, medical care and trauma care, especially for in children injury. Before you start, let me introduce because some of them we know, but some of them they don't know. I think about you. Actually, Professor GAUZY, Jerome GAUZY. He's a professor of pediatric orthopedic surgery from Toulouse, I mean, as he mentioned, and from France. And professor of orthopedic surgery, actually, he is our very intimate friend. Not only friend, actually, we can say he is the father of Myanmar scoliosis surgery and also father of Myanmar spine surgery, and also he, you know, our honorary professor of pediatric orthopedic surgery. He's been with us for 17 years, and he's been in Myanmar many times. Actually, since 2005, he's been in Myanmar at least twice a year. And he came to Myanmar and then with the team and he trained us. Actually, I myself and all the spine surgeons from Myanmar, we learned spinal surgery from Professor Jerome GAUZY and Professor Jean-Luc Diouf. And actually, they trained us. And then also we have learned since, you know, very beginning, I mean, from the beginner, and then now in Myanmar, we can have our own scoliosis surgery program. That's so I'm saying he's a father of scoliosis surgery in Myanmar. And not only that, he also helped us to develop the spinal surgery in Myanmar and spinal surgical unit in Myanmar. When we built up the spinal surgical unit, Professor Jerome GAUZY put a lot of input, even designing the hospital, even designing the theater unit and ICU. We have his suggestion and opinion and input to build up the, you know, orthopedic in orthopedic hospital, spine unit development in orthopedic hospital. And as you all know, in Myanmar now we have spinal surgery, you know, training program and doctor med science training, spine surgery for doctor med science and spinal surgical department in University of Medicine 1, we can develop because of him. And also he very much involved and then also participated to develop the doctor med science pediatric orthopedic program. And also he, Professor Ju, and then, Children Action, with the support of the Children Action and with the support of the AMFA, Professor Alam Patel, we have developed the pediatric orthopedic unit and pediatric orthopedic training program in both master degree and doctor of science degree. And not only that, but also many trainees we have sent to the Toulouse and the Marseille and Paris for orthopedic surgery and pediatric orthopedic surgery and scoliosis surgery training. Trainees to get the training there. And that's why actually Professor GAUZY is very much, support, and then also he is one of our teacher and honorary professor in orthopedic in Myanmar. And now when we have a coup, since day one, he's been supporting us, not only, academic, but also equipment and also financial support. That's why I would like to say thank you so much, standing with us, standing for Myanmar, and helping for the federal development of the, our revolution, to get rid of the military dictatorship and to become a federal democracy union in future. So I don't want to take that much time. I would like to invite Professor Jerome GAUZY to give a lecture and to take the floor. Thank you so much, Professor Jerome. And then we all, remembering, and then also we all, appreciating all that what you have done for Myanmar. Thank you.
Thank you, Professor Zo. So, I want to help you as I can. So now I can only help you with lectures. And so we try to do a program, and we will begin slowly with a generality of fracture in children. And after, we try to do other lectures with other teachers we organize. And I want to say that I have a lot of friends in Myanmar, so I want to help you as we can and continue to see you, and maybe in the future come back to Myanmar with you to continue teaching and friendship. So for fracture in children, these are generalities. You have to understand well that children are not just small adults. And for example, in children, you have a big cartilage and not only the bone. And that make a difference when you take an X-ray, for example. When you see that, you see that here you have something you cannot see, but there is cartilage here, as you can see. For example, this is an MRI, and when you have a fracture, maybe sometimes the part of bone is very small, and you can misdiagnose the fracture because of the cartilage in children. And you have also biomechanical differences, because in children the bone is more porous than in adults, so that may limit the extension of a fracture line. And also the bone in children fails in tension like in adults, but also in compression. And in children, you have also a periosteum thicker and stronger than in adults. It can produce callus more quickly and in a greater amount than in adults. So in a child, you have different fracture types. that are special for children and not seen in adults. We can see sometimes a subperiosteal fracture, that's called a hairline fracture. And you see it's a very small line here. Because the periosteum osteum is stronger, you have no displacement, and this is a benign condition that you can apply a cast and it heals in 3 weeks. It's okay. Special fracture in children. Second type of special fracture is a green stick fracture. In that case of green stick fracture, only one cortical is broken and the other one is only flex. Like when you try to break a green stick, and so when you want to reduce this fracture, you have to break also the second cortical that is not broken at that time. This is very frequent in the child. Also, you can have a traumatic bowing bone that it's called also a plastic deformation, because in a child, the bone may be bent up to 45 degrees or more before the fracture occurs. And when you release the pressure, this curvature can slowly, but the bone can slowly but incompletely straighten itself. And this fracture is due to microscopic shear fracture. So you can see an example here where you have a green stick fracture of the ulna with this cortical is intact, and here a traumatic bowing bone at the level of the radius. And in that case, because you have no callus here, you have a poor remodeling. So when you reduce, you have to straighten yourself the bone, because you cannot account for remodeling with growth. So it's very important. Also, you have another benign condition that is buccal or torus fracture, because the bone at the metaphysis area is not so strong. You can have a compression failure of the bone, and it occurs, so as I said, near the metaphysis due to the greatest porosity of the bone at that level. This is a buccal here and here. This is a benign condition with healing always in 3 weeks. Now we have to talk about the remodeling, because in children you have growth, and with growth you can have a remodeling of malunion. So in that case, you see the remodeling can occur at 2 levels. First, at the levels of the fracture due to an asymmetric growth of the periosteum, and also at the level of the growth plate between the epiphysis and the metaphysis. So that at these 2 levels, with growth, you can have a remodeling and a relaxation of the bone. So you can tolerate some amount of displacement of the fracture. And the remodeling occurs very early after the fracture, in the months following the fracture. And the quality and the quantity of remodeling depends of different factors. These factors are the age of the child. Of course, the younger the child, the more remodeling you can have. Also, it depends of the location of the fracture, because in the child, the growth plates are, some are fertile, the other no. So the remodeling occurs near the active growth plates. That means it occurs near the shoulder and the wrist, and near the knee at the lower limb. And also the remodeling occurs if the displacement is and the deformity is in the axis of mobility of the adjacent joint. That means that if you have a fracture, for example, at the wrist level, and if the fracture is a posterior displacement, because this posterior displacement is in the plane of mobility of the wrist, and it's an active growth plate, you will have total remodeling, it's okay. But if, for example, the fracture occurs at the inferior part of the humerus, and if the displacement is in rotation, of course, that it's a bad condition to have a good remodeling. So in that case, you need to reduce well. If you don't do that, you will have a malunion in the future, because you can have a poor remodeling. In rotation, usually when you have a malunion in rotation, there is a poor remodeling. Now we can see example of remodeling. You see, this is an obstetrical fracture. It's a young child, and of course we apply only a bandage, and we can have healing of the fracture, and you can see a quite total remodeling 10 months after. So this is a benign condition, no need to do surgery to reduce, and you do nothing, only bandage, and it's okay. This is another example of a fracture of the superior metaphysis of the humerus, and in that case we applied also only a bandage. We let the you see the displacement like that, because the young child, we can see the growth plate open here, and also we know that it is an active epiphysis, growth plate here. So we can count on a remodelage in the future. So we let like that. 1 month after, you can see the malunion, but the callus is okay. And you can see after 2 months, beginning started of remodeling, after 1 year, and after 2 years, it's okay. Because we are the child is young, and it's near an active growth plate. Another case in a distal metaphysis of ulna and radius. You see the callus at 3 weeks. Of course, it's not well reduced, but we know that this can remodel very quickly and easily. So we let like that, and you see at the 6 weeks and 6 months we have a very good remodeling. So sometimes in fracture in children, you don't need to have a perfect reduction, because with remodeling, the child will be good after a month. Now we have to talk about growth plate injury, because the fracture occur very often, about 30% of cases at the level of the growth plate, and with a higher frequency in teenagers. And if you have an injury of the growth plate, this injury can stop the growth, and so you can have growth disturbance in around 10% of cases. So you have to predict and to prevent this growth disturbance. Some words about the histology of the growth plates. You can see here a growth plate at the microscope. So here, this is the growth plate, for example, of the radius here. So you have the epiphysis at that level and the metaphysis here. So the growth plates, there are 3 zones. The first zone, close to the epiphysis, is the resting zone. That's mean you have small cells here, and they multiply. This is the multiplication of the cells here. So it's the zone the more active. After that, the proliferative zone, the cells organized in column like that. And after, this is the hypertrophic zone. At that hypertrophic zone, there is a disorganization of the cells, the matrix, and the beginning of calcification here. And after, with vessels coming from the metaphysis, this zone transformed in mineralized and in bone zone. So you have to know that this is the active zone where the cells are multiplying, and this is the more fragile zone. So if you have an injury of the growth plate, the fracture usually cross this zone, go through this zone, but it is not the zone of the where the cells are multiplying. So with that, you and also you have to know about the vascularization of the epiphysis and the metaphysis. There are two separate vascularization, and sometimes if you have an injury with a total displacement of the epiphysis, you can have a necrosis in certain locations, like in a femoral neck, for example, or in the radial head. So, concerning injury of growth plates, you have to know very well the Salter and Harris classifications. Very important. There are 5 types, but we can see for example, four types of fracture. The first type, Salter 1, is a fracture that crosses only the growth plate. The type 2 is a fracture that crosses the metaphysis and the growth plate. Type 3, the fracture crosses the growth plate and the epiphysis. And type 4, the fracture crosses the metaphysis, the growth plate, and the epiphysis. Why it is important to have to recognize these 4 types? Because, as I say, the fragile zone that where you have the fracture is this zone, the zone hypertrophic. So and the metaphysis is here, the epiphysis is here. So when you have type 1 and type 2, this is type 1 through the hypertrophic zone, type 2 through the metaphysis and hypertrophic zone. So the rest zone where the cells are multiplying is intact. So in that case, maybe the growth can continue even you have an injury here and the displacement. But if you have type 3 or 4, type 3 is through the growth plate and continue to the rest zone. So you have an injury of these cells that are very important to continue growth. And also in type 4, it crosses the metaphysis, and all the growth zone, even the rest zone. So you can have in type 3 and 4 growth arrest and deformation or discrepancy. So we continue with example. These are Salter type 1 and 2. So, for example, this type, only the hypertrophic zone is involved and the rest zone is okay. So, of course, there is a big displacement. You have to reduce this displacement. But if you don't reduce very well, never mind, because the rest zone are intact. And after you apply a cast, and after you have a good healing, and the growth will continue. So type 1 and 2 are usually benign conditions. So you see examples here. This is type 1 of the radius at the level of the proximal humerus, at the level of the distal fibula, and at the level of the proximal tibia. This is a benign condition for the tibia, for the growth plate, but not so benign because in that case you have to check very well the popliteal artery and the vascular zone. Sometimes it's dangerous at this zone. Type 2, you can see very well, this is a fracture of the fibula at the metaphysis level, and type 2, it goes through the metaphysis and the gross plate, but the rest zone is intact. Of course, you have to reduce and apply a plaster in that case, and but usually it heals very well with without any problem. At the level of the first phalanx also, this is a type 2 Solter and Harris. But sometimes you can have a boy with a trauma, very painful, but nothing on the X-ray because the cartilage you cannot see on the X-ray. So in that case, you have to suspect a fracture, but not displaced fracture. So in that case, you apply, you see nothing here, you apply a cast and you see the child 1 week or 10 days after. And at that time, you can see a small widening of the gross plate with a periosteal reaction. That means that this child had a Solter type 1, but not displaced fracture, but it's a benign condition. Now we move to Solter type 3 and 4. In that case, you can have a bad prognosis because the fracture cross the gross plate and go at the level of the resting zone. So in that fracture, it's like when you do a transection of the gross plate, and you can have a bone bridge at the level of the fracture. So you have to reduce very well the fracture because always you have the bone bridge, but if the bone bridge is very thin, growth can continue to occur and there is no problem. But if the bone bridge is bigger because you didn't do a very good reduction, of course, if the bone bridge is bigger, you can have a gross arrest with a deformation. So you have to remember that in Solter 1 and 2, you have to reduce, but you can accept not so good reduction. But in Solter 3 and 4, you have to reduce very well, and very often that need surgery if you can do it. But apart from this 4 type, you can have also the 5th type, Solter type 5, that is complex appear in complex injuries. And in that case, you have a crush of the gross plate. And sometimes you cannot see the crush on the X-rays. So in this type 4, sometimes it's the diagnosis is not very easy at the beginning, but you have to suspect this type 5 when you have a very big injury. For example, in that case, you see is an injury of the around the wrist. You can see here there is a displacement, so you can say, oh, it's okay, it's a Solter 2 with a metaphyseal fracture here, and that continue to the gross plate. But you have to suspect because of the very big displacement, a crush of the gross plate during the injury. Of course, we do only a reduction under general anesthesia. You see a very good reduction, so you can be satisfied with the reduction, but you have to follow the child because after that, because of the crush of the gross plate, the growth stops at the level of the radius, and you have a deformation with growth because of the ulna continue to grow and the growth arrest at the level of the radius. So radial deformation. Then after we have to perform an osteotomy of both the radius and the ulna to restore a good anatomy. Also in that case, this is a Solter 2 of the distal femur. You can see the metaphyseal fracture with continue at the level of the gross plate. And in that case, we do a reduction with a screw. The screw doesn't cross the gross plate, so it's in a good position and with a perfect reduction. But at that time, I think you can have Solter 2, but associated with a Solter 5. That means that you have a destruction of part of the gross plate due to the amount of injury. And if you follow the patient, after that is good, you see, but you can it can appear deformation of the distal part of the femur due to a bone ridge at the posterior part. So when you have a child with a gross plate injury, of course, you treat him in emergency, you follow him until he's the healing, and after you have to check to see 6 months or 1 year after if the growth continue and if there is no problem with growth, because sometimes you can have a Solter 5 associated and that you cannot diagnose at the at the beginning. Here you see there is a fracture Solter 2, just a little part of the metaphysis and continue at the level of gross plate with a mild displacement with not it's not a problem. You can apply only a cast, but you see we come back. At that time, you can see it's okay, it's a benign condition, we apply a cast, but you have to follow the child because you have to advise the family, the parents to come back 1 year after to see, because there was also a crush of the gross plate and this stops the growth of the radius and you have a deformation of the wrist, radial deformation that need an osteotomy. And if you see that before to prevent, because you know there is here stop growth is stopped here, you can stop also the growth here by a benign surgery. We will see that after. You see 5 years later with the deviation. So now concerning the treatment of the injury of the gross plate. So as I tell you, Solter type 1 and 2 are benign conditions. So in that case, of course, you need to reduce if the displacement is important, but you can tolerate residual displacement. No need to have a perfect reduction. Of course, it's better if you have a perfect reduction, but you can tolerate the displacement and no need to put very often screws or pins. And sometimes you can have a good reduction, but secondary displacement. So when you see the patient at, for example, 1 week or 2 weeks after. But if you see the patient after 10 days with displacement of the fracture, even after you put a cast, my advice is not to redo manipulations, because it's better to let like that, because with growth you can have correction of the malunion. But if you redo a manipulation, you can crush the gross plate, and in that case, you can induce yourself a Solter 5 and with the damage of the gross plate. So after 10 days, don't do nothing, only you wait. And if you have to do something, I think it's only surgery, but after healing. But for concerning Solter type 3 and 4, in that case, as I told you, you need a perfect reduction, and very often you need to apply surgery. And Solter 5, of course, you cannot diagnose at the beginning when you see the children in emergency. So because it can occur, you have to observe and to see the patient at least 6 months or 1 year after the injury and after healing. Now here you can see this is a Solter type 2 of the radius with the posterior tilt, and in that case, what to do? Only to apply a cast, and that's okay and survey. But we apply a cast, and the cast is not very well done. So when you treat with a cast, you have to very well done the cast to avoid the secondary displacement. In that case, the plaster is not very well done. So there is a secondary displacement. After 2 weeks, we saw that. So what to do? As I told you, nothing, because if you try to redo a reduction, you can crush the gross plate. So this child is young, so you let like that, and after he will heal very well, and with growth, you will have a remodeling, perfect remodeling. So after cast removal, it was like that. So we explain to the parents that it's a benign condition. They don't have to be afraid. You wait, and after that, it's okay. So when you do a plaster, when there is a displacement, you can reduce the displacement, and you put the joint in the opposite way of the displacement to keep a good reduction. For example, in that case, it was a posterior displacement of a distal radius, and so we reduce and apply a cast with the wrist in the flexion. Concerning type 3 and 4, as I told you, you need to prevent the growth problem. So you have to reduce very well the fracture. So in that case, it's a mild displacement, but if you let like that, you see is the Salter 4. If you let like that, you will have a bone bridge here, and you will have a gross disturbance. So you need to do surgery if you can, that case we screw the distal part and the metaphysis also like that. Of course, you will have, even if you screw with a perfect reduction, you will have a bone bridge, but very small, and too small to have a gross disturbance. And you notice that when you pin the fracture or when you screw the fracture here, you don't have with screw, you cannot cross the gross plate, because if you cross the gross plate with a screw, you induce gross plate injury and gross problem. So always let intact, when you screw, let intact the gross plate. You can cross the gross plate only with small pins. That's only small pins are tolerated. You see, in that case, it's maybe, if you don't know, it's a mild displacement. You should say, so the ankle is with a good axis. We can tolerate that. You apply a plaster, but after that, of course, it's displaced. It's a Salter 3 injury, and you will have a bone bridge here. And you see, after that, there is a bone bridge, and with a deviation of the ankle. So in that case, you need to do surgery and to put a pin or a screw here with a perfect reduction. Now, concerning gross disturbance, what are the risk factors of gross disturbance after gross plate injury? They occur with a high energy comminuted fracture that provoke Salter 5 fracture, and also in Salter 3 and 4 if the treatment is not well done. And of course, it occurs not immediately, but after months, because it occurs after the growth. So the clinical aspect, you see, for example, if of that case, you see the clinical aspect after 12 months with deviation of the ankle. So you need to follow the child, and if this appears, you have to apply a treatment. So when you follow the child, you can see the Harris line. It's Harris line, that means the line of gross arrest. When you have a trauma of a bone with a fracture, so you have for a small time gross arrest, and you can see this with this layer here, this the Harris line. That means that you had a trauma at that time, and after the gross stop, and after continue, and that means that you had at that time gross an injury around the bone. And you see this line is very parallel of the gross plate. That means that the gross is okay, is good. In that case, you see we had a Salter 3 injury. We put the screw with a good reduction, but we are afraid of an associated Salter 5 with a crush of the gross plate here. So we follow the child, but it's okay now because we can see the Harris line is good, parallel to the gross plate. So we can say the result is good. There is no gross disturbance. But in that case, you have the Harris line here, and you can see that is not parallel to the gross plate. So here gross continue, but here gross is stopped. So in that case, you can say that you will have a gross disturbance, and you need to do something to avoid the deviation of the metaphysis in that case. So here, for example, an example of a gross arrest here. In that case, you have a big trauma around the knee, the femoral part. Of course, it was treated with reduction and pinning, but there is an arrest of all this part of the femur is a more active epiphysis, and you will have not a deviation but a length discrepancy, and that we have to treat this discrepancy. Concerning gross arrest, so you will have a total gross arrest. That means you have an inequality, but also you have an arrest only on a part of the gross plate, and you have a deviation of the bone. It's like if you do an epiphysiodesis, if you put compression at a part of the gross plate, you have a deviation, and if you have an injury and with a bone bridge, it acts like this plate, and you have a deviation like that, valgus deviation you have to deal with. So when there is a deformity, you have a lot of manner to manage. The first is to do a deformity correction with an osteotomy, and you apply a plate. For example, here there was a bone bridge with a valgus deviations at the end of gross, so you cannot manage with gross. So in that case, we perform an osteotomy of the distal part of the femur with a good correction. But sometimes you can prevent the deformity, and when you see that you have, for example, a lateral bone bridge, you can apply screws or plate or what you want to complete the epiphysiodesis and to avoid the deformation. So how can you do that? You have a different way to do. The first described years ago by Femister is to go through the lateral and medial part of the gross plate, and you cut a part of the gross plate, you return that, and you put in the like that, and in that manner you create two bone bridge, lateral bone bridge, so you stop the growth. Also, you can apply staples like that. It's an old method also, and very easy to perform. You create a compression at the level of the growth plate, so you stop the growth. Another technique is easier, and it's the technique we use now, is to put screws that cross the growth plates, and when you put these two screws, you stop also the growth. If you want to stop only a part of the growth plate, you put the screw at this level of growth plate. For example, this is an example of a child with trauma of the distal femur, the contralateral distal femur, that create a growth arrest. So we perform very early, 6 months after, when we see the growth arrest also of the contralateral femur to avoid the limb inequality. But of course, you can apply this technique only if the child is older, because if you do this technique, for example, at 5 years old, you shorten too much the limb, so it's not an indication. These are indicated after 11 or 12 years old. Another technique is very easy. If you don't have enough screws or staples, you can do by percutaneous approach. You do a small incision, and with a curette, you curette the lateral part of the growth plate, and you destroy the cells, the growth plate, and you stop the growth. It's also a technique, but this need to have an imaging intensifier to see the growth plate. And finally, I want to conclude with this example. You see, this is a 2-year-old boy with a fracture, totally displaced, of course, you see, but you see the child is very young and is close to the active growth plate. So you know that if you apply a cast, it's okay. The child will heal, and after with growth, it will remodel very quickly, and you have a very good result. So not to do big surgery so only you put a cast, and that's okay. But in that case, the surgeon who sees the children, he wanted to reduce well. I don't know why, but he reduced very well, and he put a key wire to keep the reduction. So of course he had a good result in that case. And after 1 month, he was very happy, and everybody was very happy because and he removes the key wire. But you see, the key wire was here. So he creates a bone bridge, an artificial bone bridge, while he put the key wire. So it's not a good, it's a very bad treatment. And what happened after that? Of course, a bone bridge, and with the growth, with the deviation by growth of the wrist. It's not an indication. So it's very important to know that the child can remodel, and don't do a big surgery. Things that with growth, if the child is young, it can remodel, and don't do very big surgery, and don't apply very big pins or screws, and only very often do treat it by reduction and cast. And you see, because if you put a key wire or something more than 10% of the diameter of the bone, you create artificially a bone bridge, and you stop of the growth. Only you can sometimes pins you can apply pins that cross the growth plate when you have to keep the reduction. Of course, in that case, it was a fracture of the proximal growth plate of the tibia, and with a very unstable reduction. So we need to keep the reduction by pins, but use small pins, and do only one way. Don't do a lot of way, because if you do a lot of pins, you create artificially a bone bridge. So you have to keep in mind this example is and to treat this fracture mainly with reduction and cast. And of course, if you have a Solter 3 and 4, you need, and in that case, surgery and very good reduction. So, and I stop here. And in the future, we will see specific fracture around the, for example, the elbow, fracture of the femur. We discuss about that, but now I finish with this first lecture. And if you have questions, I can answer. And thank you very much. And we will continue to help you and to teach and to be with you. Thank you very much. Jesu Timbate, what do we say?